Good evening, friends, and welcome back to the Thursday evening PG teaching session brought to you from Sion Hospital, Mumbai. We thank the authorities at Sion Hospital for allowing us to conduct these classes, and we thank Aristo Pharma for an educational grant. As we have announced earlier, for a few weeks, these classes are not webcast live because the hall is under renovation, so they are conducted in another hall. But the recording is put up immediately after the class on the website, so you all can watch the recording, and local students are encouraged to attend live. We start with today's class, and the first case is being presented by Dr. Aditi.
Hello. Good evening, everyone. I'll be presenting the Thursday clinic long case for today. 7-year-old female, first by birth order, born out of third-degree consanguineous marriage, resident of Dharavi, hailing from Uttar Pradesh, Muslim by religion, Sheikh by community, was brought and informed by mother, who is reliable, with complaints of loose stools since 5 days, fever since 4 days, complaint of inability to walk since 1 day, and lethargy since 1 day. The child was apparently alright 5 days ago until she developed loose stools, which were watery in consistency, small quantity, 3 to 4 episodes per day, yellowish, foul smelling, not associated with blood in stools, vomiting, or pain in abdomen. Then the child developed fever, which was high grade, undocumented, associated with chills, not associated with rash, intermittent, subsided on medications, and the child was active in the interfebrile period. Then, over a period of 2 days, the child first developed inability to walk, followed by inability to stand on both feet and sit. She was also unable to get up from lying down position. However, she was able to move her legs in bed and lift her legs above the level of the bed. She could also lift her hands above the shoulder and hold objects. The mother also noticed lethargy in the form of decreased activity and excessive sleepiness since 1 day. On inquiry, the mother gives history of urinary incontinence since 1 day in the form of involuntary passage of urine in pants. However, after passing urine, she could sense that her pants were wet, and this is in a previously continent child by day and night. There was no history of seizures or headache, no history suggestive of any cranial nerve involvement, no history of any sensory deficit, no history of abnormal or involuntary movements, no history of nystagmus or tremors, no history of neck pain, visual disturbances, no history of any recent vaccination or dog bite, no history of any chronic drug or toxin consumption, no history of head trauma. There was history of some outside food consumption 2 days prior to the onset of these symptoms. During the course of stay in the hospital, the child underwent some neuroimaging and received some IV medication for 5 days, following which her power improved, and by day 6, she was able to walk unassisted. Currently, she can walk unassisted, lift her hands above the shoulder, hold objects in her hand. She is passing urine and stools normally and is continent for both. In the past history, there is history of bilateral swelling of face in the parotid area, suspected mumps, 10 days prior to the onset of this illness, for which symptomatic medication was taken, but the child was not admitted anywhere. It was also associated with fever, which developed 1 day after the swelling, which was mild, undocumented, not associated with chills, rash, intermittent, subsided on medications, and the child was active in the interfebrile period. There is history of measles 1 year ago, treated symptomatically, and the child was not admitted anywhere. Antenatal and birth history. Antenatal history is uneventful, registered pregnancy, routine antenatal visits done, 4 ultrasounds done which were said to be normal, supplements and 2 doses of TT injection were taken, no antenatal complications. It was a full-term vaginal delivery, 2.5 kg birth weight, cried on stimulation, history of NICU stay for 3 days in view of meconium stained liquor, but no O2 support was required. There is no history of neonatal jaundice or any neonatal convulsion, and child was discharged on day of life 5. She is immunized till date as per the national immunization schedule, developmentally attained all milestones at appropriate age, and currently goes to school, studies in the 2nd standard, good scholastic performance, and plays with peers. Dietary history-wise, she consumes a mixed diet, eats from all food groups, but there is a calorie deficit of 340 kilocalories and a protein deficit of 6.4 grams. Family and socioeconomic history. There is history of pulmonary COX in the grandmother 2 years back, for which she has taken 6 months of anti-COX treatment, but the family screening was not done. No other significant family history.
Just show us the details of the loose stools. Okay, so what do you make out of the first symptom, loose stools for 4-5 days? How would you analyze that? And then we add on the second and the third symptom.
These are probably viral induced loose stools. She had history of having outside food consumption also. The loose stools are small in quantity and no associated vomiting or.
So, outside food gives you viral infection or bacterial infection? So, why do you call this viral? Come on, so generally how we decide viral, bacterial, I just want a revision of all the points.
Bacterial tennis.
Usually viral is associated with vomiting, preceded by vomiting followed by loose stools. And bacterial may pain in abdomen and the loose stools predominates, along with blood in stools at times.
Okay. What else? Fever, viral or bacterial? Both. So then how does it help in differentiating or does it not help?
Child was active in interfebrile period. Usually viral infections will have normal activity or normal child within interfebrile period. A bacterial infection will have a more sick child. So he will be probably dull in the interfebrile period.
Okay. And what about the quantity of stool? Is the anatomy of viral and bacterial stomach GI infection same or different? Both are diarrheas, no? So same anatomy, right? Yes or no?
Bacterial can involve both small and large bowel, and viral usually involves small bowel.
Very good. So what is the implication?
There will be viral will be large diarrhea, large volume diarrhea. Child can be with fever or without fever. Usually sickness depends on amount of dehydration, how much the loss is there, and associated with blood in stools points and pain in abdomen, all everything points to bacterial.
Okay.
I think what is most important is the age of the child. Do you have any comment on age of the child
Sir,
who
hold it
presents with
closer.
such symptomatology?
Sir, hold it closer.
Age-related symptomatology.
Sir, in infancy, we would suspect a viral diarrhea that is more common during infancy, and maybe in the toddler age group or school-going age, we'll think more of bacteria.
See, the point I'm making is, at this age, viral is most unlikely. Why do I say that? Viral is most unlikely, not that it cannot happen, but less likely. Most of the viral infections provide reasonable immune response for some time, in fact, long time. Of course, measles, mumps, etc. for even many years, but in general. And therefore, another thing is that when there is one viral infection on, others mostly don't count at all. And viral infection is not preventable, because everywhere you touch there is a virus, like a rotavirus, for example. So you do develop immunity, to majority of our common community viral infections. So 7-year-old is not an age for a viral infection till proved otherwise. Okay. Then question is it a bacterial infection? Bacterial infection may start often with fever, though the stools could be loose, watery, and by another day change to mucus and blood. But this did not start with fever. So this is unlikely a classical bacillary dysentery. That's another common cause. Could it be any parasitic infection? Unusual. Loose stools, loose, watery, unusual. So we don't have a typical bacterial, viral, nor parasitic infection. What remains? Could it be non-infective inflammation, starting of an inflammatory bowel disease? What is your comment on that? Because that's another loose stools at this age. What would you say? Could it be a beginning of IBD, and by another day or two you will get some mucus, blood, whatever? And the answer is almost no. It doesn't start with watery stools. It starts often with not too many stools, often mucus, vague symptomatology. Okay. And therefore it is not non-infective inflammation to begin with. What remains now? Two things remain. One, are we dealing with an unusual infection? And what is unusual infection? Like a Campylobacter. Okay. We have no idea. We are not trying to develop an etiological sense on this. But I know it's not typical viral, not typical dysentery, okay, nor an autoimmune inflammatory bowel disease. Unlikely. We keep that in mind. But it hasn't started with fever. It's rarely very acute onset. And if it's acute onset, then it's almost simulating a bacillary dysentery. So this is not that kind of an IBD. So one is Campylobacter. Another is it toxin-related diarrhea? Okay. So the point I'm making is when you get such a history, you start asking them, and she did mention that he had some food outside. Okay. So is it some toxin related? We just start with a possible groups, and therefore this child either has an unusual infection, not common, or it is toxin related. Now this is the first impression. Now he gets fever. It only means that there is some more inflammatory response coming up. It doesn't tell you why, what it is. But it did not start with fever. So the infection seems to be almost with no fever or very mild fever, but develops fever. It could be they have not noticed it. Yes, we keep all that in mind. But we know that there was no significant fever. So possibly something else is happening. What else could happen? Toxin has gone in, started with diarrhea. Toxin gets absorbed, now starts having a systemic symptoms. Is it a toxin related? What toxin, which organism? We have no idea. But could it be toxin related? So point is, this would be a thought process. Okay. And at this age, with this thought process, we would have almost told a parent that you get admitted. Because we don't know where we are moving. Okay. We know it's toxin related. We know if it's a Campylobacter, again, very strong immune problems coming up. We have no idea. And therefore, the correct way of thinking is, even this child is not dehydrated, this child has not been very malnourished as she provided the diet history. So he is not at risk, but the symptomatology seems to be at risk. And one would have said, I would be happy if you get hospitalized or give them a red flags and say, if anything happens, come back to me. Yeah.
So 2-3 small other points. Also look at the number of stools. So there's only 3 to 4 stools a day. Usually infections would lead to a larger number of stools. So that's also another number to be focused on. And now my question is that fever came after 5 days of loose stools. So now this fever, does it make it a bacterial infection or a viral infection? Because we get cough, cold followed by fever, no? In viral infections of the respiratory tract. We get cough, cold yesterday and fever today. So this fever which has come after 5 days, now does it make it an infection?
The fever is the next day of loose stools. Means the fever has developed from the second day of loose stools. So loose stools since 5 days and fever since 4 days.
Usually for infantile diarrhea, the analysis is watery diarrhea and non-watery diarrhea. Watery diarrhea, unless proved otherwise, we take it as viral. Blood and mucus in stool, we take it as bacillary dysentery, but the history is not very easy to obtain. Also, the bacillary dysentery initially starts with watery diarrhea. Often it is associated with abrupt onset of high fever, and a fever can be very high. Sometimes even a child may go through a convulsion, which we call as toxic encephalopathy or Shigella encephalopathy, after and foul smelling stool, after which the small sticky mucoid stools with blood comes. History of tenesmus is not, all diarrheas may have pain except perhaps cholera. But tenesmus means you have to go, he goes and passes trains, comes back and again he wants to go. He may not pass a very small amount of stool and go. So the frequency is unusual, but amount of stool passed every time is very small with lot of pain. So that history-wise suggests tenesmus. Later onset of fever is quite unusual, and that alerts us that this is something going on. If it is associated with cough, cold, etc., you know that this particular diarrhea may not have been. So onset of fever in infective diarrhea is usually in the beginning and later on followed by vomiting and loose motion. And as just said that toxic diarrhea or unusual organisms are always to be kept in mind.
Okay, now he's developed a inability to walk followed by stand. So where is the anatomy of this problem now? What do you think? Why does this child now have inability to walk and stand? So from this history, from your description, this is upper motor neuron or lower motor neuron? And why?
Could be both, sir.
Okay, it could be both. Why? Justify both.
If it is upper motor neuron, then it could be spinal shock. Or if it's lower motor neuron or muscle pathology, then
No, one sec. What do you mean by spinal shock?
spinal shock is flaccid paralysis in the upper motor neuron lesion initially.
Correct.
By
So in this description, are you able to make out whether this is flaccid paralysis or spastic paralysis?
since the child is not getting up from the, he is not making any posture.
No, what I mean is this description is only telling you about the pattern of the weakness. As yet, I don't think it is clear whether this is spastic or flaccid. So don't get into spinal shock. So what I'm trying to say is how presence of what would tell you this is upper motor neuron. Yeah.
Altered sensorium.
So she is able to move her legs and lift her legs. So like the power is still around 3/5. In LMN usually the power would not be that much.
I don't think that's correct. I mean, see, it's not that LMN is always power 0. It can be power 3 also. No? I mean, I get your point that LMN often is stronger or more loss of power than UMN, but it's relative. So, is there something here which tells you that this might be UMN?
There is history of decreased activity and excessive sleepiness. So along with the CNS involvement, we have some encephalopathic picture also.
So that is something which, if it is pointing to a cortical involvement, then it suggests a possible UMN, right? Now we had a background of loose motions. Could this just be electrolyte disturbance? Hypokalemia?
It's just a small quantity, 3 to 4 episodes of loose stools in a well-grown child, so less likely an electrolyte disturbance. Could be an infection which is triggering a CNS involvement.
Yeah, so for electrolyte, as she rightly said, quantity is not there and he is not a malnourished child, so unlikely. Plus, of course, electrolyte might be waxing and waning. You may have abdominal distension, paralytic ileus, vomiting, other symptoms, right? Okay. Fine. We move on to the next.
Just a point to make on this. The story starts with inability to walk, but which means he could stand. Okay, as far as the story goes, and then followed by inability to stand on both feet. So the child could stand but could not walk. That was the beginning of the story. Now if you look at that point, what must have happened? Obviously looks neurological. If it is an acute onset upper motor neuron, then where is the anatomy of this? If you have a difficulty in walking, what does it mean? Possibly he could still stand, which means support. To my understanding, that means the power was reasonable to make him stand. Okay, but not able to kind of move further. So I start feeling that it must be a power getting less and nothing else. Okay. If there was the tone that is the problem, then tone doesn't come up suddenly like this, and if there is an acute onset upper motor neuron, then there is a paresis also. So this looks like a slowly coming up paresis, and then it goes on increasing. Okay. And then he cannot even stand, okay, unable to get up. But thereafter she says, but moves legs in the bed. Now what is that? So power is getting gradually worsening. When the child can move the legs in bed, maybe against gravity, eliminating gravity. It could be 3/5. At this age, 3/5 is not normal. And therefore I feel that this is starting as a paresis. And if that is so, then acute onset upper motor neuron lesion has no reason to start in both the legs with paresis. It can happen only with hydrocephalus coming for whatever reason, which means there has to be some preceding story. It could be occasionally a gait problem, but this is not a gait problem. This is inability. Otherwise, even a frontal lobe can present almost like a gait disturbance. So to me, this is not directly an acute upper motor neuron. Therefore, I would pitch in for a lower motor neuron. Now, if it's a lower motor neuron, then the question is, what is it? It looks like that first walking is difficult and then standing, which means he cannot balance the whole body weight on his feet. Therefore, the problem has started from feet, and the hands seem to be all right. So I can start seeing the progression of the disease starting from bottom there, but not in the hands. So had it been a general peripheral neuropathy, the hands, feet both could have had a distal beginning. So this looks like an isolated beginning of the feet to begin with. Till then, the hands seem to be reasonably well, even above the head. So hand seems to be not affecting. Am I really therefore getting a story of a GBS coming? If you have to analyze very, very closely, then I feel it's a lower motor neuron lesion. Starting from bottom, maybe the hands are not much involved as yet. And if it is so, then we know that this is some infection induced. Okay. Now the question is, whenever you are talking about some such thing, then we will have to consider whether it's like a typical GBS, whether it's like what is known as AIDP or AMN, whatever it is. That we will not be able to make out at all. And I don't think we will have to make out that only by follow-up or by investigation. So the story does look like that. Now, having said that, it's a lower motor neuron, acute onset. So, is it an anterior horn cell? The answer is no, because anterior horn cell is rather quick and localized. This looks like generalized both legs. So, it is not typically an anterior horn cell. So, it has to be not a nerve, as I said, upper part of the body is not involved. And therefore, possibly we start getting the GBS-like syndrome coming up from that. I think that would be my analysis.
Later on, he developed bladder and bowel involvement. Now, while we may understand that bladder bowel may be a rare transient phenomenon for a GBS, but we start also thinking that this is much more wide than what we think, only localized to. Also added to that, he was drowsy. So there seems to be much sort of a well-spread involvement of the central nervous system. Though prominence may be to the peripheral nerves, there may be some involvement of the cord, and he was not so bad to become drowsy. And with just GPS, unless he was starved, etc., he shouldn't have. So drowsiness plus involvement of bladder perhaps suggests to us that it is much wider than what we probably will think of. But GBS, of course, is the first diagnosis. I just wanted, sir, you to elaborate from the history. The UMN and the UMN is spastic. This is flaccid. So from the history, how do you?
I think I only thought that if it's an upper motor neuron, it has to be acute in this child. And acute involving the lower limbs. So acute involving the lower limbs is unusual upper motor neuron, and the only time that one has seen is if it's a frontal lobe lesion, then that too there is a gait disturbance, not inability to, but you have some problem coming up in a gait. Otherwise not. Therefore I pitched on the acute lower motor. Now it's unlikely a transverse myelitis or anything to the spinal cord because it would have been acute. And GBS has a negligible sensory involvement, but that is transient. In fact, if there is a persistent bladder, then you have ruled out a GBS. So transient sensory system involvement, which often is not even noticed by the parent, and therefore we have a differential diagnosis of an AMN, only motor, and not sensory at all. But typical GBS or AIDP is also a mild sensory and a major motor, and a sensory being transient is often missed. So possibly that still holds true. If you had a mild such evidence that, oh, for a while he could not, and you have something happening there, that there was incontinence, okay. So if it is not lasting, then I'm not worried about it. If it was transient, that is all right. Yes?
Fine. So, so we've discussed UMN versus LMN and all the anatomy. Now, what do you think is the pathology? Apparently, this child has recovered soon also, right? Recovered within 5-6 days. So, how does that help you? What do you think? What kind of pathology will recover quickly?
So any inflammatory pathology?
Yeah, so inflammatory immune mediated, right? So that will recover quickly, fine. So it still stands that it could be GBS with a transient bladder involvement. Anything else?
My question would be, would you have started some IV medication for this child? So what made them start the IV medication? I'm sure it's not an IV antibiotics, so it must be an IVIG. Okay, but what made them start? And they said that neuroimaging was done. What do you think they found in neuroimaging? that made them give IV medication, which I imagine is IVIG. What do you think must be MRI findings to justify such therapy? Give a thought, doesn't matter.
What do you look for on MRI in GBS?
Or let me ask you another question. We are thinking about GBS. What can MRI show in GBS? How early? We are on day 5, day 6, nothing more. What must have they found?
In the spinal cord, there will be some
Root enhancement.
root enhancement.
Caudal
Right?
enhancement.
So root enhancement on contrast MRI.
And the only point is, there is some lethargy also.
Yes.
Now, we don't know what that lethargy means. Why, like what Dr. Khare said, it's not only periphery but also something happening up there. So maybe MRI also showed something up there or something inflammation around the spinal cord, around the roots, and that's why they must have done that, right?
So, if there was no encephalopathic pictures, how could we differentiate between CNS versus muscular etiology? The weakness.
Correct. So this is clinically, this is a very acute onset clinical problem. So muscular etiology, as in if the pathology is muscle, acute onset muscle pathology is very, very uncommon unless it is electrolyte or, in the olden days what we used to call as polymyositis, which was painful muscle inflammation. There is no pain here. So this is not muscle. So we are debating between CNS because of the drowsiness, etc. And we are debating between peripheral nerve, means nerve root like in GBS, even peripheral nerve as in a toxic peripheral neuropathy, it's too widespread, is in all upper limb, lower limb, everything. So it has to be, in LMN it has to be nerve root, and if at all it is UMN, then something like, if that spine, then disseminated encephalomyelitis, ADEM. But for that also, it's not that he's got a seizure or he's become unconscious. He just has a little drowsiness.
You raised the question, muscle, good. Now we have said that acute myositis is out. Pain would have been a feature and it would have been generalized. But which inflammatory muscle disease, that is myositis, presents not with pain but with weakness?
Though it's not acute.
All muscle disorders come with acute onset, inflammatory, pain. Okay. Or chronic, yes, weakness. But which myositis, inflammation, presents with weakness? And the answer is dermatomyositis. Okay, pain is not a big feature. The feature is inability to move. Of course, there could be, and in all rheumatological disorder, one symptom may precede by even days or weeks with the other. And therefore, if at all you are considering the muscle weakness, then do think about dermatomyositis, and then there would be some clues somewhere to say that there is some inflammation, right?
And so, do we consider encephalopathy in this patient?
So that history of drowsiness and sleepiness has to be dissected. Okay, how long was it, and whether, when the patient was being woken up, was the patient coherent sufficiently or not? So that will tell us whether you can call it encephalopathy or no.
And I think two things are not uncommon in almost many illnesses. One is hyponatremia in an acute illness. Acute pneumonias, acute meningitis. There could be a hidden hyponatremia. Okay. Similarly, a hypokalemia. If somebody is not taking adequate electrolytes for 3-4 days, simply for 3-4 days, okay, you will start getting hypokalemic, whether symptoms are obvious or hidden, or whether they are subclinical. And therefore, even 2-3 days of simple viral infection, when you are reasonably active, when fever goes down, But after fever has completely abated, you start feeling weakness for a day or two. You say, I'm lethargic, not lethargic by cortex, but I don't want to move because you are hypokalemic. And that's why outside your hospital is a person selling potassium. Okay, every hospital has somebody outside, okay, because they know that everybody inside is a hypokalemic. Okay, but my question is, as we have discussed this, why should hypokalemia come after 2-3 days of illness where I have not taken electrolytes? Is it that kind of a thing? I'm not losing, no? I have no diarrhea, I have only body ache, headache. I'm not losing potassium.
Did you get the question? So what is the physiology of potassium homeostasis?
So the answer is potassium is constantly being excreted as well as secreted. Tubules secrete potassium and they don't know you're not taking. They may not excrete because you don't have a pool, but a secretion continues, and therefore even 3 days, if you're a borderline hypokalemic, you're not been feeding well, and the kidney is secreting potassium, not knowing that you're not taking it, and that's why that 2-3 days, symptoms are not paralysis, but symptoms are weakness, and in a day or two I recover, right?
So now tell us your clinical diagnosis and we'll go to examination.
So my impression on history, 7-year-old female with acute onset quadriparesis with bladder involvement, with features suggestive of encephalopathy, with recent history of mumps, in a birth and developmentally normal, immunized till date child, to rule out GBS, ADEM or post-viral encephalitis.
Okay, stop. So immunized normally, as
yes.
in,
Yes, immunized normally and till date.
so why did this child get mumps
Also, measles.
and measles? So we'll come one by one.
The NIS doesn't include mumps, it's MR vaccine.
So the government immunization schedule does not include mumps, they give MR, so measles and rubella. So that might explain mumps. Suppose somebody has taken MMR, can he or she still get mumps? So how good is the MMR vaccine to prevent measles, mumps and rubella?
It has a 95% conversion, seroconversion rate.
For
Measles.
and for mumps 80 to 85%. So mumps is the weakest link. So once in a while you might find somebody who's taken MMR but still gets mumps. Why did this child get measles? Come on, some thoughts. So whenever it's measles, the first thing that you should ask is, again, ask all the details. So don't take their word for granted that it was measles. Because in India, any fever with rash is diagnosed as measles by lay people, not necessarily by doctors. So now how will you confirm 1 year back ka illness that it was measles on history? In other, So 1 year back rash, where it started, they'll remember. They'll say it started when I was in Andheri.
High grade fever.
Fever and
High
rash
grade fever.
correlation.
So what is the hallmark symptom? If it was not there, you will say it was not measles. Cough, bad cough. So never diagnose measles in the absence of bad cough. Okay? So if there was no bad cough with that illness, then it was unlikely to. Of course, you'll ask for high fever, you'll ask for generalized rash, all that, right? So that is one possibility. And then, of course, if it was genuinely measles, then you know that the MMR vaccine is temperature sensitive and all those issues. So whether the cold chain was maintained or wrong, means poor quality vaccine was given, etc., etc.
But in India, most of us get exposed to all these infections. even if we don't take vaccine. So do you think this child must be not immunocompetent? Measles, mumps, what is happening? He has been in a crowded place, I'm sure. If you are in Mumbai, that's enough. Crowded means what more crowd you want. Okay. You must get all infections. You must get all immunity. Okay. So I think it must be immunodeficiency. And that's why all these complications.
Child's growth has always been good, and these were never severe infections requiring hospitalization. So I don't think it's. And till now she has been okay.
Till
No
6
past
years of
history.
life, she has not got any major infection requiring
Growth
hospitalization.
is not necessarily affected in an immune deficiency. Okay. If you are well treated, there is no problem. But these illnesses have no treatment. So they would have got into complications. But had it been a pneumonia, meningitis, 2-3 illnesses, he could have been getting better with a prompt treatment in spite of immune deficiency, because the antibiotics work to kill the germs, and he has many other areas of immune system working. So you are right that you would have said viral infection would have got into complications, right? But this child has a complication, no? That's what I'm saying. Then this child has a complication, so I'm coming to same now. If I could convince you it's a complication that would have happened, this is complication.
An exaggerated immune response to the infection.
That complication is really a multi-system, like COVID doing, etc., not necessarily immunocompromised, but yes, it would have disseminated, whereas this is a localized immune response. So this is a hyperimmune response, and we are talking about a hypoimmune problem.
Coming to measles, because you people may not have seen measles as we have seen. Cough, coryza and conjunctivitis, high fever. Cough is a must. Cough is just not mild cough. Troublesome and persistent. But much more important diagnostic thing is, on day 4, when the rash appears, now you may not be able to take from the history what's the sequence and all. When the rash appears, the fever goes even higher than what it was earlier. So if it was 102, after the rash it has to be 103, 104. And if the rash appeared and the fever subsided and child looks relatively all right, it is exanthum subitum, also known as roseola in symptom. It is not uncommon at all to see roseola in small babies. And very typical high fever, तीसरे दिन rash आया, बच्चा खेलने लगा, fever subsiding. Measles exactly the opposite. So also coming to mumps. If it's a bilateral parotid swelling, then perhaps mumps is more in favor. But can mumps be unilateral? Sometimes it can be, or one can come and the other can. So in unilateral mumps swelling, how do you make out? Another common differentiation by mumps, especially on one side, can simulate a deep cervical lymphadenopathy. So how do you separate clinically?
Clinically, what do you look for to decide is this a parotid swelling or is this a lymph node swelling?
Treatment is quite different. So in a parotid swelling, the first thing that happens is this particular depression disappears. And when the parotid swelling is fully developed, there is as much swelling in front as behind. And if you take a pen or a pencil and keep it here, from the upper pole to the lower pole of the ear, that is pinna, there is as much swelling in front as it is behind. So this will not happen in lymphadenopathy. The swelling will be either behind, or if there is something here, it will be behind. And it's a very simple clinical diagnosis, which is almost also if you give, of course that's for parotid. If you give some lime juice or something to a child with parotid involvement, he will immediately complain of pain, because a sour thing will stimulate stimulates secretion. In a rare case, you want to make sure if you do amylase, then even in parotitis due to mumps, the amylase is raised, not necessarily in pancreatitis. So it is, of late we are seeing cases of mumps, but in that hidden lymphadenitis is also seen. The management is different. Diagnosis is simple on clinical examination.
Examination.
On examination, the child was examined in supine position and was lying with lower limbs extended and upper limbs mid-flexed and supinated. She was afebrile, pulse rate of 96 per minute, regular with normal volume, respiratory rate of 24 per minute, regular, saturation was 98% on room air, blood pressure was 100 by 60 millimeters of mercury in right upper limb, which corresponds from 50th to 90th centile. Peripheral pulses, central pulses well felt, and extremities were warm. Anthropometrically, the weight of the child was 13.3 kg to an expected of 22.4 kg, which is less than -3 standard deviation. Height was 123 centimeters to an expected of 120.8, which corresponds between median to +1 standard deviation. And the BMI was 8.8 to an expected of 15.4, which is less than -3 standard deviation. The interpretation being severe thin with wasting. On head-to-toe examination, skull was normal in shape and size, no facial dysmorphism. Left-sided facial palsy was present, eyes, ears, throat normal, trunk, abdomen normal, spine, genitals normal. There were no neurocutaneous markers and no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. On systemic examination in central nervous system, the child was conscious but irritable. In cranial nerve examination, the second cranial nerve, direct and consensual light reflex present. Extraocular movements were normal, range of movement was full and free. Sensation over the face was present, corneal reflex, jaw jerk present. In the seventh cranial nerve examination, on attempted smiling, deviation of the angle of the mouth to the right was present. However, the child could close both the eyes, frowning was preserved, nasolabial fold was preserved, and there was no drooling of saliva. Rest cranial nerves, hearing was preserved, gag normal, uvula central, no swallowing difficulty or change in voice, and shrugging of shoulders was present, tongue was central, no deviation. On motor system examination, the child was lying in supine position with lower limbs extended and upper limbs by the side of the body. The bulk of the muscles was normal on both sides and equal, no visible wasting. The tone was increased in the left upper and lower limb, and the right upper and lower limb tone was normal. Coming to the power, neck flexion extension, neck centrally, neck flexion extension was 4/5, and shoulder, elbow, wrist on both the sides, right and left, the power was 4/5 across all joints. In the lower limb power, on the right side, the hip, knee, power was 4/5 and ankle flexion extension was 4/5. However, on the left, the hip flexion extension, abduction, adduction was 3/5, knee flexion extension was 3/5, and ankle flexion extension was 2/5. Reflexes, superficial reflexes were preserved, and on deep tendon reflexes, biceps, triceps, supinator bilaterally was 2+, knee was bilaterally 3+, ankle 2+, and the plantars were extensor bilaterally. There was no sensory deficit, there were no tremors, nystagmus, no involuntary or abnormal movements, no meningeal signs, and no signs of autonomic dysfunction. In CVS examination, S1, S2 was heard, no murmur, per abdomen soft, tender, no organomegaly, and respiratory system examination, air entry was bilaterally equal and clear, no adventitious sounds were heard.
So just interpret your CNS findings.
So sir, in CNS findings, cranial, higher motor function wise, there was irritability on examination, and there was also history of some lethargy. So some features of encephalopathy are present. Then there is cranial nerve involvement of the 7th cranial nerve, which is present.
Upper motor neuron or lower motor?
Upper motor neuron involvement. And left-sided upper motor neuron facial palsy. And on motor system examination, means left is affected more than right, but there is quadriparesis. And the reflexes, however, except knee, all the reflexes are 2+, but with extensor plantars. And rest, otherwise there is no other sensory involvement or no other cerebellum, etc. involvement.
So how would you describe this anatomically? Is it left-sided hemiplegia? Is it bilateral hemiplegia? Is it quadriparesis?
It is more of quadriparesis only.
But you have a left facial also, and you said left is more than right.
upper motor neuron type
Ah.
facial.
Yes, the facial palsy was left upper motor neuron only. So like diffuse asymmetrical involvement is present, which is involving the left more than the right.
So where is the lesion for this paresis?
Lesion seems to be cortical, but not like one vascular territory. Diffuse cortical lesion.
Okay, why do you say that?
So because of the involvement, like there is quadriparesis, facial palsy, even bladder involvement is present. So it could be diffuse involvement.
So bladder involvement is also cortical.
That could be means more of spinal. For it to be cortical, then it would have had to be the frontal lobe, but no other feature is there. So that could be spinal. But basically the involvement as a whole is involving the cortex and the spinal cord.
Yeah, so what I would have probably thought is that there is evidence of one left side hemiparesis in the form of increased involvement and left facial. So that is one lesion. And there is another lesion which is explaining the right-sided weakness. It is not dense, nor is it associated with a right-sided facial. So it's certainly not right internal capsule. So it's a patchy lesion of the right side. So that makes it multiple lesions in the CNS. And then if the bladder is because of the spine, so multiple lesions and spine. So that is the way you would probably analyze this. And that irritability as a encephalopathy. Its power is a little funny. It's symmetrical on both sides, 4/5.
So lower limb power is 3/5. And even as history-wise, the lower limb functions were affected more.
And among the other signs, like bilateral plantar extensor is a clear-cut sign of UMN, right?
Yes.
So that is something which is, if your technique is correct, then obviously that's undisputable. So that's why it is bilateral UMN, so bilateral lesions, but patchy lesions.
involved.
She said that there was difficulty in raising the upper limbs also.
No.
After lower limbs, the upper limb came, but with 4/5 power, involvement of upper limb.
No, on history she could raise her hand above the shoulder and hold objects as well.
I feel that power must have gone down in all muscles, but when it comes to a mild paresis, it is often seen as inability to stand, walk, etc. Whereas the upper limbs, he could do that. I suppose that's the only way to go by, isn't it? So he did not have, but looked like that it was progressing, okay, and it's clear now that bilateral plantar extensor, there is no doubt, but the whole story looks to be patchy, disseminated. That's why the D there, okay, and there could be an M there also, we don't know. So we have really an ADM as that not as GBS.
So we understand the difficulty in interpreting UMN against lower element only from the history. Because both of them have presented with, they can present, we thought weakness and therefore element, but even the upper limb did present with weakness. We are not very sure whether the weakness in upper limb, I would expect tone more affected than power. So I don't know whether we should have interpreted as that he was able to stand, that means the power was reasonable, and therefore upper motor. But to jump to the diagnosis of UMN just based on that is difficult. So we understand that it's not very easy to separate one from the other only from the history.
I think what we have learned from this is that when we asked about cranial nerve, we could have asked whether he could drink well. See, if there is a facial palsy, there is some problem of drinking. Okay. As a retrospective feeling, where did we miss something? Again, when it is a lethargy, we must look at what is lethargy, and I think best way is to go by AVPU. Is he answering to the call? Is he answering to the pain? So we know the degree of lethargy, because lethargy could be muscle weakness or lethargy could be a brain cell weakness. So I suppose we have learned that some more details in the history when you get such story might have made us pick up. Though he said to begin with that when there is a drowsiness, there is also up there. And GBS has nothing up there. Okay.
But patchy involvement.
Yeah, absolutely.
My impression, a 7-year-old female with acute onset quadriparesis, with left UMN facial palsy, with bladder involvement, with features suggestive of encephalopathy, without any seizures or sensory involvement, or any hearing or vision involvement, in a birth and developmentally normal, immunized till date child, is most likely a case of acute disseminated encephalomyelitis.
Secondary to?
Means preceding viral illness.
Preceding viral illness.
Secondary to mumps. Mumps was there 15
Yes,
days
it
back?
can be secondary to mumps.
It can very well be due to mumps.
That only,
And these
preceding
immunological
viral
complications can occur after. I remember it was mentioned in book that in chickenpox the neurological complication can occur as much as within 6 months. And I have known an adult who had chickenpox after 3 months. She developed a little chorea, and that chorea is now, many years have passed, but she still has that residual chorea. So immunological complications, not necessarily immediately, and we would like to, you can do specific antibodies, etc., etc. What do you, if I were to do a lumbar puncture in mumps, what will you see? Mumps meningitis is well known. In fact, almost all cases of mumps have subtle meningitis or at least CSF. If I do CSF in all mumps, I'll get an abnormal CSF in many without there being any involvement clinically. So how do you separate it from bacterial meningitis?
Means lymphocyte predominant.
Sugar normal, cells are increased, sugar normal, so you say mumps meningitis. Mumps meningitis is not uncommon.
Why first attack of multiple sclerosis?
Means right now, at this point, we cannot say, means we'll have to wait, but it could always.
Yeah, but why did you think of
Because
that?
of the patchy asymmetrical involvement, so there could be multiple areas of demyelination. That's why.
Okay. Any investigations have been done?
This is the image of the facial palsy. And on investigations, neuroimaging was done, an MRI brain plus spine was done for the child. And that was suggestive of multiple ill-defined asymmetric non-enhancing T2 flare hyperintense lesions, and it was involving the cortical and subcortical locations of bilateral frontal, right parietal, right occipital, subcortical region, and left peritrigonal white matter, left insular cortex, bilateral thalamocapsular region, right more than left, bilateral optic radiation, again right more than left, and left midbrain, and hemipons and periaqueductal region. As well as the MRI spine had multiple patchy long and short segment T2 hyperintense and T1 isointense signals with subtle post-contrast enhancement in cervical and dorsal and dorsal lumbar spinal region, so suggestive of ADEM.
The involvement is so extensive, but clinical manifestations are not. Almost always it is so in ADEM that you have on imaging much more than what you think clinically it is.
Okay.
Thank you.
Thank you. We'll move on to the second case for today.
These days we have permanent deafness following mumps. It's what's come in the newspaper. I wonder whether, I mean, if that is so, there is quite troublesome, but must be quite a few cases only.
Yeah, you can start, Dr. Priyanka.
Good evening. I'll be presenting the short case for today. A 7-month-old female child, second by birth order, born of non-consanguineous marriage, resident of Dombivli, hailing from Ayodhya, Hindu by religion, brought by parents with complaints of multiple episodes of paroxysmal events since 5 days. Patient was apparently alright 5 days back when the parents noticed multiple episodes of paroxysmal events in the form of tongue thrusting associated with fisting of bilateral upper limbs and jerky movements of distal upper limbs. Drowsiness or any focal neurological deficit. On inquiry, parents also say that the child was conscious during these episodes. For these complaints, they took the child to a local doctor, and from there, the child was referred here. There was no history of deviation of angle of mouth, frothing at the angle of mouth, uprolling of eyeballs, no history of fever, ear discharge, cough, cold, no history of vomiting, loose stools, lethargy, irritability. There is no history of similar complaints in the past and no history of seizure disorder in the family. There is no history of any previous admissions. ANC history, the pregnancy was registered, all USG scans were done and they were told to be normal. TT injections were taken. The mother was taking iron and folic acid supplements, but the mother was not compliant, and she had received parental iron in the 3rd month of her pregnancy and a blood transfusion in the 7th month. This was taken on history, documents were not available. No other ANC complications were there, no history of rash, fever or lymphadenopathy in the mother during pregnancy. Birth history. This was a full-term normal vaginal delivery with a birth weight of 2.5 kgs. Baby cried immediately after birth. There is no history of any NICU stay, no history of neonatal jaundice. Dietary history, the child was exclusively breastfed till 6 months of age, started on complementary feeding at 6 months of age, and she was started on some powder which was taken from a local shop. Mother consumes all the food groups except for the meat and meat products. There is calorie deficit of 550 kilocalories in the mother and a protein deficit of 20 grams per day. The child is immunized till date according to the national immunization schedule. Developmentally, the child achieved head holding at 3 months of age, rolling over at 5 months of age, but now the child cannot sit with support. The child does not approach for things. He can recognize parents and cooing is present. GDD is present. There is no history of similar complaints in the family members. The elder sibling was 9 years old and she passed away at 5.5 years of age due to some insect bite and complications due to that. Socioeconomic history, she belongs to the upper middle class according to the modified Kuppaswamy scale.
Wait, go back. Yeah, so go to the second slide which describes this. So what do you make out of these movements as per the description? What all they can be? Infantile spasms, okay. So why you thought of that, and is it something in favor, something against?
There is a thrusting movement of the upper limbs, and are usually present only in the awake state. Usually the infantile spasms are also seen immediately after waking up and usually disappear in sleep, and are short lasting, multiple events in a day and the age of onset.
Anybody else? Any other thoughts? So you mean infantile spasms as in benign myoclonus of infancy, or you mean the infantile spasms of West syndrome? And is there something which is missing for that? So how does that myoclonic movement of an infant appear? How does it look like?
Head drop is also there, and this does not look like a seizure, this picture. It's most of myoclonus like.
Correct. So see, why doesn't it look like a seizure? No. Present on awake state and disappears on sleep is a characteristic feature of what? Not myoclonus. Myoclonus is a seizure.
Involuntary.
Is it a seizure or no, myoclonus? So it is not characteristic of a seizure to be present in awake state and disappear in sleep. Involuntary movements are characteristically, all involuntary movements are absent in sleep. So that is a characteristic of any involuntary movement. Under involuntary movement you have many. Chorea, athetosis, dystonia, tremor, whatever, right? What I am trying to tell you is that, see, one is myoclonus is a seizure, right? But it is so transient that change of sensorium is not easy to perceive, okay? So that is one. Second, it generally, so that head dropping will be if the infant is upright. But in an infant who is sleeping, it will not, you won't be able to make out whether the head is dropping or no. Sleeping as in the supine position. But I thought that even the lower limbs are involved to some extent. So it is a flexion of the whole body and not just the upper limbs, though of course that is something which is difficult for them to pick up. What about tongue thrusting?
That could be a type of abnormal movement only.
Like?
Chorea.
Yeah, so you see typically tongue thrusting in chorea. Can it be a seizure? Yeah, tongue thrusting can be a part of a seizure. But then it should have that episodic nature, and at that moment for those few seconds or whatever, the baby shouldn't be responsive to anything, right? Anything else? Could it be a drug reaction? Have you seen this metoclopramide?
Induced.
Yeah. So what happens in that?
Dyskinesia.
Huh? Dyskinesia. So what happens? Clinically, what do you see?
Means that jerky movements.
So there are jerky movements of the neck to one side, okay? And there could be limb movements also, right? So it's intermittent. So that's another thing. So this is just to keep thinking of what are the various possibilities. Now in this case, with this description it is difficult unless you actually see the movement. So in practice you would have told the mother that can you record a movement and show, and then you would have seen the movement, maybe you would have made a little more out of it, right?
I think as he has said, myoclonus is a seizure disorder. Now, typical seizure has some post-ictal phase. Okay, of course, eyes are open or whatever. It's not possible to know it here. But what is important is that when there is a jerky movements, it's not only spasm, but it's myoclonus. Okay, to that extent, this is a myoclonus, but without any apparent post-ictal drowsiness, which only means that it is so transient that it is not perceived. The point is that if you call it a myoclonus, then let it come from the higher centers and not a peripheral spasm. And I think then all that is further clear that there is a global developmental delay, etc. Right? And I think when there is a transient myoclonus like this, to pick up whether there is post-ictal or not is not very easy. And sometimes they are so frequent. But what is typical is it's like an abnormal movement, but it is also a seizure. So what appears that it disappears in sleep is like an abnormal movement, but being a myoclonus and not a spasm, we would expect it to be a seizure as well.
Come to your developmental history again. There are some things you have to look at finely.
And sir, in like myoclonus or infantile, in myoclonus, like the proximal movement is more. Here there is like jerky movement of the distal upper limb, because that flexion movement is like the movement at the proximal.
True, but on history it is difficult to make out, no? So with so much of distinction.
I didn't understand what you mean by disappears on feeding. That means while the child is getting these movements, if you feed, the movements disappear.
Yes, the parent gave that history while they were feeding, or when the child slept, it would disappear.
But so let me put it ask you other way. So otherwise it's there all along throughout the day?
Yeah, they are present.
Huh?
Now, even now, the child has those movements. Like it is present continuously. It disappears on sleeping, and the father also said that when the child is fed, then also it disappears. And he also said it also disappears on crying. But when I examined the child, even when the child was crying, it was present.
No, so if it's there throughout the day, then it can't be myoclonus, because there have to be break in between for it to be so many. Like you can't have 200 or 500 myoclonic seizures a day. So if that details has to be important. What about this history? Anybody? So is this developmental arrest, or is this developmental regression, or is this global developmental delay?
So motor milestones, at least head holding, rollover, fairly at the appropriate age the child has attained, and child is 7 months, cannot sit with support yet, but
So the child's age is 7 months. So at 7 months, we cannot label it as global developmental delay. The motor milestones look fair only. The social are also good. Does not approach for things like for fine. It could be because there is some involuntary movements of the distal limbs. Therefore, the child is not attempting to approach for anything. Could be like not a delay in the development itself.
So the better way to put that would be that till rolling over 5 months, motor is normal, recognizes parents and cooing is present, so that is up to 3 months you are okay. But after that you don't have enough details. Does not approach for things means never approached things, because approach things is much earlier. So used to approach things and now has stopped approaching one side or both sides because it's a hemiparesis or it's a regression of that milestone. Then cannot sit without support. Again, whether this was never achieved or what is important. And then you need to know about other cognitive milestones around 6-7 months. So you need to ask about stranger anxiety. You need to ask about whether the child wants to play peekaboo or some such things. So laughs aloud or no, responds to no. 7 months they may well respond to their name also sometimes. So all those details are important. So what I'm trying to say is from this we cannot really differentiate whether this is now arrested in all fields, and certainly we can't say whether it's regression, right?
Can he hold the head now? Means you said holding head at 3 months. But does he hold the head now?
Yes, sir.
So that is maintained.
Yes.
And now just go back to now recognize parents. He never did that.
No, he's recognizing even now.
Even now.
Yeah.
Okay, and cooing present. Only cooing?
That's
Yeah.
what. So
Babbling is not present, monosyllable, bisyllable.
babbling is not
They have
present.
said cooing is present.
So babbling is not present. Cooing is present.
No, so babbling was never achieved?
No, it was never achieved.
So why are you calling it global developmental delay? Okay.
All the domains are not affected.
All the domains are not affected, and there's all lot of difference. No, means if our,
So according to the definition, if at least 2 domains are affected, then you label it as GDD. Hence, she might have labeled it as GDD.
Recognize as parents at 5 months is different story. At what age did you start recognizing parents? At 3 months, was he recognizing parents and he now continues to recognize parents? Because recognition of parent is a good milestone which eliminates your physical or motor milestones. So did he recognize the parent even when we was 2 to 1 of the earliest milestones? So did he achieve that and now has it, or now he has but he never recognized the parent? This is one thing parent will never forget. So was he recognizing that 2.5 to 3?
probably she may not have asked those details, but so we learn that these things are important for us to make a proper judgment, right? Okay. Fine. Go on.
7-month-old female child with history of tongue thrusting associated with tremors of bilateral upper limbs with ANC history suggestive of anemia in mother in an exclusively breastfed child immunized till age is most probably a case of infantile tremor syndrome, hypocalcemic convulsions, to rule out epileptic seizures, hypocalcemic convulsions.
So 2-3 things. One is here you have said in summary associated with tremors. Now when you described the movement, you said jerky movements of the upper limb with fisting of the thumbs. So that is not the description of tremor. So now it all depends on what the parent told us. But if the parent were to describe tremors, they would use the word that the hands are shaking all the time. That would be their word, right?
Shivering. He said shivering movements are present.
Correct. So again, in the history, we need those details, that whether those shivering movements are there all the time. So when you use the word jerky movements, it led us on a different track. Whereas tremors is not really jerky movements, right? Okay. Then, as far as DD of epileptic seizures, so your history almost rules them out. We discussed myoclonic seizures, but then you said it's happening throughout the day, continuously. So if it's happening continuously, then that is ruled out. And what about hypocalcemic seizures? What is the classic way in which hypocalcemic seizures would present? No postictal drowsiness, yeah, but how many? Like 2, 3, 10, 15, 30, 40? So again, what I'm saying is, here you are saying that these movements are there throughout the day. You can't have hypocalcemic seizures throughout the day. You'll have 2, 3, 4, whatever in some span, but then the body's defense, the compensatory mechanisms come in, and then you'll have a long patch where there'll be nothing, right? So that's not the pattern of hypocalcemic seizures.
I may just suggest that when you want exact details of the history, it is not wrong to do it yourself and ask them, does it happen like that? Suppose you want to know myoclonic jerk. Does it become like this, or it is like this? They are not doctors. They will describe in their language. There's nothing wrong in demonstrating what you feel is right, and then you can, no, ऐसा नहीं, पहले जैसा बताया वैसे होता है. So you can definitely say what it was. And hypocalcemia, hypocalcemia in an infant can give rise to a generalized seizure. That carpopulmonary spasm usually in older. But I thought there was a generalized seizure, there should have been loss of consciousness, even if it was hypocalcemia. Bilateral seizures must give rise to loss of consciousness.
We'll get the child here.
आप लेके बैठिए।
Come on, two of you come other than her and tell us what you can see. Come, Rutuja. Stand on one side so that the camera can. You can come this side also.
So, child.
आ रहा है
looks-
कैमरा में कि लाइट चाहिए? हाँ.
Child is fairly grown. There is obvious facial spasms continuous with preserved sensorium and
So facial spasms as in the whole face is contracting?
there is very evident tongue thrusting with no then there is also movement of the bilateral upper limbs. Distal muscle involvement appears more than the proximal muscles. Lower limbs are also involved. Again, the distal more than proximal. And there is just skin lesion.
So there is a continuous tongue thrusting movements and vibratory oscillatory pattern of the upper limb movement of the bilateral upper limb involving sometimes the lower limb also. Also the skin changes are present globally, a reticular pattern of skin.
I'm not much convinced whether distal is more than proximal because even the arm is moving almost at the same frequency and is the oscillatory pattern also of the tongue or it is not there?
It is there.
Rhythmic
so the
movement.
oscillatory pattern
of
is
the
everywhere.
tongue.
So why is this word oscillatory pattern important? So almost equal movement around an axis, which classifies it as a tremor. Because the other movements, the chorea, the athetosis and all, they are not around one axis. So the moment you describe it as oscillatory, it is almost stamped as a tremor, right?
Can we not say the distal muscles are more involved even in the lower limbs? Flickering more than the jerky movements of the proximal limb.
So what I mean to say is that when you use this sentence, that distal muscles are more involved than proximal. So, every word is important. First of all, in which neurological situation distal is more than proximal? in peripheral neuropathy. Okay. Now we are saying distal muscles are more involved. So are we talking of muscle power or wasting or what as more involved? So if the movements are visible more distally than proximally, how do you relate it to involuntary movements? Athetosis is more distal, chorea is more proximal. So that word which you use, distal more than proximal, you have to be very clear whether you are talking of distal power more affected, distal movements are more, or what. You get my point? Okay. Do you think he can see?
Yes, he is interested in surroundings and fixes with the person talking to him.
He follows me.
Yeah.
Right.
Yeah. He
Follows the
follows me
face.
very clearly.
Fine. Now, next, what will you examine?
Anterior fontanel,
Hmm?
CNS, anterior fontanel and
Yeah, anterofontanel, okay, but yeah, with the musculoskeletal system, what do you want to examine?
tone of the muscles.
Yeah, tone and power.
Power.
So do that quickly, here only, roughly. What do you think?
Tone appears to be normal, but there is the distal muscles are giving a very hard resistance to the movements, the finger muscles.
Could this be epilepsy partialis continua?
So that means involving all limbs is unlikely. Usually it is focal, one limb continuous type. So all four limbs is unlikely.
So the moment it is bilateral, it is ruled out, right? Because that's a focal thing.
So the tone is normal only in all four limbs, and he's moving all four limbs, so power is also more than 3/5. Like no obvious focal neurological deficit any.
Neck holding, we would like to see if patient.
You don't have a gaddi here, no? ठीक है, see ऐसे, how will you see?
Partial, it seems like a partial neck holding. On axillary suspension, there was a good tone. And in ventral suspension, he could horizontal. He could hold the neck just momentarily above the plane of the body. So suggests around 3 months of developmental age.
Yeah, fine. So anything else?
So I think what we could have picked up early really is that, yes, you rightly said jerky, but then it's very frequent. What is typically a tremor? Much distal than proximal, but frequency is tremendous. Okay, and I think that is what this child has. Now, if we know that this is tremors only, then the question is, the milestones have certainly not up to the mark, but they are not too bad. What does it mean? That in the first few months, this child must have been all right, and that's what the history suggests. And therefore, this is not one of the classical degenerative disorder, but it's slowly degenerating. So very minimally. So let's call it as a kind of a late onset infancy and a very slow progression. And even the slow progression is not uniformly affected. To that extent, I think we know that if this child was completely all right, what do you think about the nutrition of this child?
It is not up to the mark. There is some.
So do you think this child is severely malnourished? Let weight be whatever. This child has got a reasonable muscle mass. There is a reasonable fat there. So this child is not severely malnourished. He may not have grown well for varieties of reasons. Okay. But otherwise, even in spite of all that, he could follow the face very well. This itself must be making him come out with much more words or whatever. So we need to look at the cognition. But when he was doing those gestures, and when we talked, even the baby looked at on our side as if he could also sense that somebody is talking from the other side. So the cognitive responses are not too bad, okay, but all these tremors are coming in the way of some motor part, including the motor part of the speech kind of language. And therefore I think we have come to a conclusion that you're right, this is tremors, but this is a very slow progressive disease and it's a late infant onset. Putting all that, anemia, tremor, pigmentation syndrome may be fine, but where is pigmentation? And where is anemia? Okay, so let's look at whether it's slowly coming up, basal ganglia lesion, okay, and with, see, whatever little anemia, tremor, pigmentation earlier was far more often seen, and one has seen a very minimal delayed development, okay. This child seems to be not so normal looking, quite involved, but not fastly progressive. So is there a clinical anemia? And then pigmentation. Possibly not severe anemia.
Some pallor is still present.
And therefore a typical anemia, tremor, pigmentation that we used to see was almost towards 9 to 12 months of age. B12 deficiency, so pigmentation there. And then the delayed milestones were very minimal. This child certainly has significant, though not severe, and I think therefore it might still have a spectrum of event, but we need to see how the progression is occurring. All this is happening in only last few days, so that's quite fast. For an anemia, tremor, pigmentation slowly arrives, and this is getting too fast. So one is a little worried whether this child is going to develop some basal ganglia disease more than just the syndrome that we talked of, right?
Fine. Tell us what tests have been done.
but you handled the infant so well. I was impressed by his, he did it so well. He told me, if I was an examiner, I said he has done it several times. Oh, holding the baby like this, the mother must be worried whether it will fall down. But he was very confident. I like the way he held the baby in all different positions. Yeah, I think that was very good, yes.
But in horizontal suspension, the normal baby, the head goes above the level of the body, well above the, yeah.
So, investigations, the child CBC had an HB of 7.3 with a hematocrit of 25.3, MCV was 101.2, MCH of 29.2, MCHC of 28.9. The PS showed hypersegmented neutrophils. We also sent a vitamin B12 level which was 200. RFT was 9 and so BUN was 9, creat was 0.4, serum calcium was 8.8. Vitamin B12 levels were 264. We also sent vitamin B12 of the mother. Vitamin B12 of mother was 100. So deficiency of vitamin B12 was present in the mother as well. Mother's CBC HP was 10.3, hematocrit of 32.4, MCV of 101.4. So now
So
like
baby's vitamin B12 is normal, no?
it's on the lower side.
But normal. So what's the catch?
Serum levels of vitamin B12 are not reliable. And you have a better test. What is that better test? Methylmelanomic acid. And I think that is the test. We should also look for whether there is any relation to homocysteine. And I think therefore B12 normal also does not rule out B12 deficiency. And to that extent that could, mother certainly is low. And she has an MCV which is a little high. Okay, so that's one pointer. There is some hypersegmented neutrophils. So I think reasonably looks like, and B12 levels are not to be worried about really.
So currently only the routine investigations have been sent, like if not yet, like it's still under evaluation. So now currently we're thinking of infantile tremor syndrome only, and we've given methylcobalamin. Injection calcium gluconate is also given because serum calcium was 8.8, and we've also started Vitcofol.
So for discussion's sake, this serum calcium 8.8, how should we be treating it?
This is not a nutritional.
My question is, forget calcium, when do you give IV glucose in somebody whose sugar is less than normal? If normal is 60 and sugar is 59.
Symptomatic.
So the same principle applies to calcium, no? So means this IV calcium which we are giving is not going to stay in the circulation and keep it there. It's going to quickly get out of the circulation. So all IV metabolic, calcium, glucose, etc. is only for that acute rise which you want, and then you have to substantiate it with oral calcium and vitamin D so that it slowly gets absorbed and stays normal, right? And how will you treat with B12? That's what I'm asking.
So injection methylcobalamin was given.
Why not oral?
Sorry?
Why not oral? Come on. We can give oral B12?
Yeah.
So why not oral? You didn't give iron injection, you gave iron orally, and B12 you are giving injection. So you want to bypass any issues about absorption 1, you want a quick rise, and you want to quickly reverse the process. So that's why you're giving parenteral, right? So it's right to give parenteral.
Actually, the villi which absorb the B12 are atrophied in a severe deficiency of vitamin B12. So given orally, absorption is not satisfactory. So in the beginning you give intramuscularly so that the villi regenerate. Thereafter when you start orally, they can absorb.
And today even the nasal B12 is available, because otherwise you have to give injection for a long time. It's not just few injections. To begin with, maybe alternate days, then maybe twice a week. You have to have a long course of parenteral B12. You can have a nasal one also, morning, evening. You take a nasal B12 and that absorption is fine. The point is that if the anemia has been existing for a long time, as he said, the atrophy of the mucosa comes in the way of, but does it not come in the way of iron?
So there is upregulation of the receptors, so that helps iron absorption.
And the reason is we take a lot of iron, of which very little is absorbed, but in terms of anemia, when the mucosa is iron deficient, in fact it absorbs iron better than the normal mucosa. So the anemic patients absorb iron better than a normal person. And to that extent oral is good enough. And there is no urgency. Here there is no urgency, but we are bypassing the problem of absorption.
How is the prognosis of anemia? No, I don't know.
I think, as far as I know, the prognosis is, let's believe it's an anemia tremor pigmentation, then the prognosis is not necessarily very normal. There is going to be some handicap. We have no idea. We haven't seen it for last maybe 20, 30 years at all. But earlier we used to see, and they remain mildly abnormal. Maybe school performance, behavior, whatever, but otherwise they did all right. But here I am little concerned, and I want really to keep a watch, because it has come up very suddenly, it has progressed very fast, and to that extent whether there is something much more getting involved or otherwise.
That's all, no? Yeah. Thank you. Any other questions?
Feeding issues of this child? Any feeding issues, because there's constantly tongue thrust? So is there any feeding issues? Because weaning should have been started at 7 months.
Yeah, so parents did say that since the child has started having these movements, the feeding is affected, or the oral intake is decreased. The child is not feeding the way he was feeding before, the frequency.
Okay. Fine. So I think we'll stop here. So we thank once again Aristo Pharma for their scientific grant, which helps us with the live webcast of these classes. As we said, the hall is under renovation, so for a few weeks we are having this recorded version which will be uploaded on the website, so everybody can see it there. And we again encourage local students who are in Mumbai to come and attend these classes physically. We meet next Thursday. Okay. So we'll just summarize both the cases today. So the first case was a 7-year-old girl who came with a non-specific illness, starting with loose motions and followed by fever, and then developed neurological deficits. We discussed whether on history we can make out whether these neurological deficits are upper motor neuron or lower motor neuron. And we said that if it is a bilateral involvement, it is more likely to be lower motor neuron. If it's upper motor neuron and bilateral, then there has to be prominent symptoms of cortical involvement. This child did have some lethargy and sleepiness, but we did not have much details about it. Then we got a symptom of bladder bowel involvement, which made us think on two lines. If it was lower motor neuron, possibly bladder bowel was transient, but we didn't have details of the sleepiness and the lethargy. Otherwise, it could have been upper motor neuron, which was bilateral involvement with cortical involvement with spine involvement, suggesting a disseminated involvement. On examination, we found a left-sided facial with a left-sided kind of hemiparesis, but also weakness on the right side, and lower limbs more than upper limbs. So ultimately we concluded, and this child was irritable also. So we concluded that there are patchy lesions all over, including upper motor neuron, CNS and the spine, and therefore clinically it fit into a diagnosis of ADEM. This child was treated with IV medications and responded very well, so everything was consistent with ADEM. The second child was a 7-month-old child who came with tremors. So now the history was maybe not very clear when we were describing these movements, but on observing the child, it was very obvious that this child had tremors, including involving the trunk, upper limbs and lower limbs. And there was some suggestion of either a developmental arrest or maybe a bit of regression. We were not very sure of that. The child looked nutritionally average, so it looked like there is possibly, if at all it's a deficiency, then it's some selective deficiency. And we also discussed a degenerative disorder, but then the onset was a bit too sudden. Whether we wanted degenerative disorders to come up little slowly and progress slowly, but it's possible that it's a beginning of a degenerative disorder. So we discussed that, and then on investigations we found that there was very much suggestive of B12 deficiency, and therefore we'll take it as related to anemia tremor pigmentation syndrome, treat with B12 parenterally and see the response in the next few days. The response should be pretty quick, right? So these were the two cases which we saw today. We once again thank Aristo Pharma for their scientific grant, and we meet once again next Thursday at 6 p.m. Thank you.